Thank you very much, Professor Graziano. It's really a great honor for me to be here today. So these are my disclosures. So when we talk about inter-individual variability of a drug in general, it's a good start to look at the general pharmacology of the drug. And aspirin, in terms of biotransformation, has not the CIP for 50 enzymes involved. Therefore, we wouldn't expect that much of variability coming from DDI, drug-drug interaction. For this reason, let's start focusing on the pharmacodynamics. The pharmacodynamics of aspirin includes platelets both in the peripheral blood and in the systemic circulation, as well as bone marrow, megakaryocytes, and pro and pre-platelet precursors. Looking at variability, of course, we need a robust biomarker, and this robust biomarker is indeed serum thromboxane B2 with this assay, which was described for the first time by Professor Patrono and Patrignani in the 80s, which nicely reflects very closely the pharmacodynamic of aspirin. So in this talk, you will be hearing very often serum thromboxane B2 as the biomarker reflecting aspirin pharmacodynamics. And this has been actually supported by a regulatory agency. This is a position paper, which it's still there, so it has never been retreated or anything. So in this position paper, it says that the regulatory requirements for the authorization of low-dose modified release aspirin formulation in the secondary prevention is indeed the serum thromboxane B2 level, serum not plasma, which are a surrogate for efficacy. So this is the drug and the biomarker to understand variability. And it's already known since the first papers from Guy Fitzgerald and Carlo Patrono, then people who were taking aspirin and then they were stopping aspirin. Here we are looking at serum thromboxane B2 percentage of baseline. So this means basically 100% inhibition. Once you stop aspirin, you don't have a linear recovery as you would expect, but rather this kind of delay, which it's approximately of 2 days, and then the aspirin, the platelet activity increases actually in an exponential way. And what was the interpretation? Because here we are talking about interpretation at that time. So the interpretation was that the acetylation based on systemic bioavailability of the drug was hitting megakaryocytes, pre and pro platelets. And therefore, this delay was associated with this pharmacodynamic association. And then new platelets were released, which had non-acetylated COX-1 from the bone marrow, and the activity was in the peripheral blood was raising up again. So this is the background, and this is the disease we will start with, essential thrombocythemia. Essential thrombocythemia has changes in megakaryocytes and platelets, which lead to increased thrombotic events. So basically what happens is that these megakaryocytes are hypersensitive to thrombopoietin. So they are bigger, they produce more pro-platelets. Pro-platelets means also activated platelets, and these platelets do more thrombosis and less bleeding. And this is the best evidence that we have in essential thrombocythemia in terms of a clinical profile. Essential thrombocythemia belongs to a group of disorders which are the myeloproliferative neoplasms. And here we looked at patients with these diseases, and also polycythemia vera is associated with an increased risk of arterial thrombosis versus matched control. This is an observational study on almost 10,000 patients from Sweden. And as you can see here, there is matched controls, and the incidence of serious vascular events was approximately 3.5-fold higher in males or females. This is a specific age age range, but the same is at lower or at higher age ranges if the patients had MPN as compared to 4 match controls for each of these point estimates. And what about the treatment? The treatment has been questioned because there is no clinical trial on essential thrombocythemia. There are a lot of observational study. This is a meta-analysis, the best we can get in this situation. And what we see here, looking at thrombosis and any bleeding, so we are putting together any kind of bleeding, and the majority of these patients was in primary prevention, is that there is a very uncertain signal for antiplatelet therapy effectiveness because of bias, inconsistency, observational data. But most of all, we have to think that also in the slide that we saw before, these patients are already by hematological guideline on primary prevention. And we observed in 2 different occasions in the past years that looking at, this is residual serum thromboxane, so what is there when the patients were taking low-dose aspirin once daily. Residual thromboxane as a function of increased number of reticulated platelets. And reticulated platelets are basically the young, active platelets in the peripheral blood. And the residual serum thromboxane was higher and higher according to the number of these platelets. So these patients had clearly a very high turnover of platelets. But most of all, you see the distribution, the variability increases as much as the reticulated platelet increase. So we have the right drug, but we need at this point the right regimen for the right disease. And the hypothesis was that newly released platelets with unacetylated cyclooxygenase isoenzymes released over the traditional dosing interval, which is 24 hours, may contribute to the variable, in this case poorer, aspirin responsiveness in essential thrombocythemia, and therefore there is a need for more frequent daily dosing. And here it comes ARES. ARES is a phase 2 trial which started 2 years ago, and essential thrombocythemia patients basically were randomized to 100 milligrams once daily, 100 milligrams twice daily, and 100 milligrams 3 times daily. And this part was double-blind with matching placebo tablets. And the primary endpoint of this part 1 was a surrogate of efficacy, which is serum thromboxane B2, with an hypothesis of more than at least 50% relative reduction of BID versus once daily or TID versus BID. And we had a biomarker of surrogate for efficacy, which was prostacyclin, urinary prostacyclin. So the trial is now running part B, so we have already decided what is happening in part B, but basically the part B of the study was intended to randomize for 20 months the standard aspirin regimens versus the optimized regimen identified in part A. And for part B, the main endpoints were persistency of the inhibition and safety, of course, of more infrequent aspirin regimen. So these are still unpublished data. So we randomized 246 patients. They were well balanced in terms of males or females. They were relatively young, 50 or a little bit more than 50 age at diagnosis, pretty lean, 25 kilograms per square meter as body mass index, and the large majority of them was on aspirin for primary prevention. And here are the results of the part A. So this is the group which was taking 100 milligrams of aspirin once daily. And we could reproduce data that we published 10 years ago, so we were very happy about that. And the 100 milligram BID and TID actually reduced it by nearly 80% the residual serum thromboxane B2. And as you can see, the variability associated with 100 milligrams once daily in this population was pretty high, and that was restrained by giving BID or TID dosing. So part B of ARES is running. It's almost halfway, and the comparison, the winner is the BID, basically. So far. So this is the first source of variability, which is associated with the pharmacodynamic, with the target, in conditions of increased platelet turnover. And we will see what ARES will tell us about that. But going to the right dose for the right patients, there is a concern on the two sides of the oceans, both by the FDA and the EMA, that we really need the right dose in special population. As Lina Badimon was saying this morning, we need precision medicine. And the reason is that basically, if we look at age, pregnancy, and BMI, there is a typical capping of BMI, even in large randomized trials, around 30 kilograms per square meter. And obesity is a problem. Here we look at body weight, classes of body weight, underweight, normal, overweight, or class 1 obesity, which is up to 35, and then over 35. Over 35 patients have very many problems, increase in DVT, in CV mortality, in bleeding. And for these patients, actually, in this population here, we give either fixed dose drugs or body weight adjusted drugs for antithrombotics. And the evidence is really little if we move toward lower BMI or the highest range of BMI, which is 34 plus in terms of kilograms per square meter. So we ran a small proof of concept study, 19 obese subjects versus 10 controls. These were healthy young patients, but were obese. Their average BMI was 39, so they were moderate to severe obese subjects which were supposed to undergo bariatric surgery. And if we look at serum thromboxane B2, that's before aspirin, no difference obese control, but then once they took aspirin for 21 days, and this is measurements at 4 hours, which should be the peak, then 24 hours, patients, controls, and 48 hours. So patients have a lower degree of inhibition, and they also they seem to have a faster recovery. We analyzed the data of the residual serum thromboxane B2. This is a log scale. Let's just keep in mind that it's a log scale of residual serum thromboxane B2 across a wide range of BMI or body weight values. So BMI from 15 up to 60, body weight from 45 up to 145. And in both situations, we were able to see a logarithmic increase of the residual thromboxane B2. And if we put, let's say, what is called an adequate response to aspirins, which is an inhibition that is at least or higher than 98%, then we will see that what can be classified as aspirin poor responsiveness is clearly located at BMI over 35 and the body weight level of over 100 with a continuous trend, as a continuous variable. So that's the last part of my talk. Actually, the inter-individual variability calls for precision medicine. And precision medicine is particularly important in complex clinical scenarios or in rare clinical scenarios, and which could be the help in this situation. So what are called the physiologically based pharmacokinetic pharmacodynamic modeling. This model is has actually at the attention of the regulatory agency. This is the first, I would say, very important paper from a public workshop of the FDA. There is an update this year where about the application of this in silico model, this physiologically based pharmacokinetic model to support dose selection. Which is very important because it highlights an unmet therapeutic need. And among the list of the situation where this model could be applied, there were specific populations and situations, and among them, obesity and disease state in terms of rare disease or complex clinical situation were listed. So, together with the bioengineers of the University of Padova, we developed, it took 3 years to develop this model, so it was not really straightforward. This model included, of course, pharmacokinetic data on low-dose aspirin, and there was plenty of this data. So as you see, the model integrates the aspirin appearance rate in the portal blood, in the systemic blood, in the tissue with various kinetics. But more interestingly, it took a very long time to reconstruct the kinetics of platelet formation, starting from the CD4 stem cells all the way down to the dying platelet. So that was very difficult to build up in humans because, there are not so many data. We have a lot of data on mice, but not that many data in humans. And again, this model, this is a PK/PD, so this model integrated the development of a platelet and the COX-1 production, disappearing, acetylation in all different compartments. So at the end of the day, this is how the model looks like. And I don't know much more about this because it's really complicated and I don't go beyond that. But this model first have to be run against a normal population. So the red dots are healthy volunteers taking aspirin and then stopping aspirin, and these are the experimental point. So at the end of the blue line is the model prediction. So the model was able to fit very nicely at the end the data, the experimental data, putting a lifespan of megakaryocytes of 4 days, which is plausible to what we see in the literature, and the platelet half-life of an average of 7 days. Then we asked the model. So this is a model. To tell us, so that's a model-informed precise dosing of aspirin in essential thrombocythemia. So there are no experimental data. That's the model which was set with a shorter lifespan of megakaryocyte, which is in agreement with the type of disorder, with a slightly shorter platelet survival and with an increased platelet count. And as we can see here, the red line is 24-hour inhibition, which goes up and down in patients taking, that's a simulation, 100 milligrams once daily, and that's a recovery. So 200 milligrams is a little bit better, but not that better. And what actually works is the green line, which is 100 milligrams twice daily. So the model was able to inform about way of giving aspirin, which is exactly the one that we saw when we looked at the data of ARES. So we also challenged the model, because the nice things of this model is that they can learn. So we challenged the model with the data on obese patients. So the blue line, again, is the model simulation that would fit the experimental data of the healthy subjects, and the red dots were the experimental data on obese subjects. So the model, in order to fit the obesity subject, had to be set to a bioavailability level of the drug, which was approximately half. So 50% normal, 25% was the situation which was able to reproduce the inhibition in healthy obese data, and you see the 24 hours fluctuation is much higher in these patients. And again, the model was looking at the bioavailability in terms of BMI. There was an inverse prediction of drug bioavailability as a function of increasing BMI. And this is my last slide. So again, model-informed precise dosing. So the model was challenged to find what was the best aspirin dosing in moderately to severe obese patients. The red dots are the healthy volunteers data, and the blue line are all the simulations that have been done taking the parameters of an obese population. And looking at the once daily dosing regimen, actually these patients would very well go to the same levels of inhibition of non-obese subjects at any dosing between 200 and 300 milligrams once daily, or the other possibility is increasing the dose frequency, and in this case, a good inhibition is reached by 75 or 85, so less than 100 milligrams per day, which may also reflect the fact that these patients do not have an increased platelet turnover. So which are the take-home messages then? So identifying the determinants of variability in aspirin response is relevant in order to hypothesize and test new ways of administering an old drug which is effective, which is cheap in the context of precision medicine. A BID regimen of low-dose aspirin could restore an adequate platelet cyclooxygenase inhibition without affecting endothelial prostacyclin in a condition of a chronically enhanced platelet generation. The model-informed precision aspirin dosing, it may be very helpful in the future, and this does not apply only to aspirin. I mean, antibiotics, anti-epileptics undergo the same path of research because this would cover huge unmet clinical needs, and this can be supported by the in silico PB pharmacologically based PK/PD modeling, and this can both instruct clinical trial or make decision algorithms. These are very interesting decision algorithms that start to come up based on antibiotics, which are based on this kind of model-informed precision aspirin dosing. But of course, this is not the end of the story. That's just the beginning, because adequately sized randomized trial, whenever possible, of improved versus conventional antiplatelet regimens in specific population instructed by in silico modeling, as well as additional refinements of the PK model will be needed in the future roadmap, because this model can also integrate population data, can integrate physiologic or data from different diseases, so they have a very wide possibility of being instructed. And the last but not least, I have to acknowledge my mentor, Carlo Patrono, Giovanna Petrucci, who's the coordinator of all the measurements that you saw in the lab, Professor De Stefano, the group of Vicenza, Alberto Tosetto in Ares, and the group at Cardiologico Monzino for the prostacyclin, the group of the bioengineers at the University of Padova, my good friend, epidemiologist at the University of Leicester, Francesco Zaccardi, my colleague Aida Ibib at the University of Beirut, all the ARES investigators and all the patients which were very dedicated, and healthy volunteers who participate to this study, especially ARES. And ARES has been founded by the IFA Independent Research Project. And I thank you very much for your attention.